In this section, you will learn about interpreting manometry and identifying abnormalities. The hallmark of achalasia is the high integrated relaxation pressure, which fails to relax during a swallow. Depending on the pressure topography, 3 subtypes can be identified. As you can see in this table, all 3 achalasia subtypes have a mean integrated relaxation pressure that is more than the upper limit of normal. The other abnormalities include peristalsis, pressurization, the pressure topography, and response to treatment. Esophagogastric junction outflow obstruction falls into the second tier of the Chicago classification. The mean IRP is greater than the upper limit of normal, but unlike in achalasia, some instances of intact peristalsis or weak peristalsis with small breaks are present. Although this does not meet the criteria of achalasia, since both these diseases have an impaired relaxation of the lower esophageal sphincter, treatment options are similar. Outcome data of treatment, however, is limited. The diagnostic criteria of distal esophageal spasm includes a normal mean IRP and over 20% premature contractions, which have a distal latency less than 4.5 seconds. To diagnose a hypercontractile or a jackhammer esophagus, the manometry should identify one or more swallows with a DCI over 8,000, with a single peaked or multi-peaked contractions. This is a rare disorder, and the patients present with dysphagia. In conventional manometry, a similar patient may have been diagnosed with nutcracker esophagus. This may be a primary disorder of excessive excitation of the esophageal smooth muscle or a reaction to a subtle obstruction at the level of the esophagogastric junction. In frequent failed peristalsis, over 30% of the swallows show a failed peristaltic pattern. There are, however, some swallows with a normal peristaltic pattern. This is not a usual cause of dysphagia, and patients do not require any definitive intervention. Patients with less than 70% of failed peristalsis have a good prognosis. Patients who border on absent peristalsis, that is, patients with over 70% of failed swallows, may be at risk to progress to absent peristalsis. In weak peristalsis, the diagnostic criteria include a mean integrated relaxation pressure less than 15 mm mercury and more than 30% of swallows with small breaks in the 20 mm isobaric contour, or more than 20% of swallows with large breaks in the 20 mm isobaric contour. This usually corresponds to a 50% or more swallows associated with a DCI less than 450. This type of peristalsis is associated with impaired bolus transit through the esophagus with a non-obstructive dysphagia. The diagnostic criteria for absent peristalsis include a normal mean IRP and 100% of swallows with failed peristalsis. Similar to weak peristalsis, this is associated with poor esophageal bolus transit. This can be associated with dysphagia for both liquids and solids. Patients with GORD, collagen vascular diseases like scleroderma, and some patients after fundoplication may show this pressure morphology. If the lower esophageal sphincter is weak, allowing reflux of acid, patients are likely to develop severe reflux esophagitis. If rapid contractions, defined as a contraction front velocity of over 9 centimeters per second, is seen in more than 20% of swallows, and a distal latency is less than 4.5 seconds, it's diagnosed as a rapid premature contraction. If the CFV is over 9 centimeters per second, but the distal latency is more than 4.5 seconds, it's a rapid contraction with a normal latency.